Good afternoon to all of you. My name is Arosha Disanak. I'm the president of the Ceylon College of Physicians. A warm welcome to this month's Young Physicians Forum and the college lecture. Just taking 30 seconds to explain to you what this Young Physicians Forum is all about. For the past maybe close upon 18 years or so, the CCP has been regularly conducting the Young Physicians Forum, where people who have just got through the MD get an opportunity, a platform to speak about their new specialty interest or some area of interest that they are developing to the rest of the physician community, so that the senior physicians get to know about the up and coming bright stars on the horizon. So, I myself have been a presenter at the Young Physicians Forum back in 2005. So now I'm the president of the CCP. So maybe some of these presenters today might be CCP presidents down the line. So it is an important career step for senior registrars. And it is that important meeting that we have here. So I welcome the two senior registrars who are going to be presenting today. We will introduce them formally later, as well as then, of course, I have the judges of the Young Physicians Forum joining us, as well as Dr. Duminda Avesinghe, who is the president of the College of Rheumatology, the College of Specialists in Rheumatology and Rehabilitation. He's our honored guest today, and he will also be chairing this session with me. Right. To start off today's proceedings, may I invite the first young physician for today, Dr. GRS Gamlat. He is going to speak to us about the role of the respiratory physician in neuromuscular disorders. He's a senior registrar in respiratory medicine at the NHSL and Central Chest Clinic, Colombo. This again is an extremely important lecture because here we are seeing how a respiratory physician steps in to a different specialty of neuro rehabilitation and contributing as part of a team effort to make the patients get better. Over to you, Dr. Gamlat. Thank you.
Thank you very much, sir, for your kind introduction. I'm going to talk to you about the role of the respiratory physician in neuromuscular diseases. In the outline of my lecture, I'm going to introduce you to neuromuscular diseases and respiratory failure associated. And then I'm going to take you through the pathogenesis of respiratory dysfunction. Then I'll tell you about the symptoms and signs of respiratory failure and how to evaluate patients clinically. And after that, I'll go through the investigations of respiratory dysfunction, and then I'll conclude with the management strategies of respiratory dysfunction. Neuromuscular diseases are a group of broadly defined group of disorders that involve injury or dysfunction of peripheral nerves or muscle. The site of injury can be the cell bodies, Schwann cells, neuromuscular junction, muscle, or any combination of these sites. Some neuromuscular diseases are also associated with central nervous system disease, but most are restricted to the peripheral nervous system. Most of these neuromuscular diseases are characterized by progressive muscular impairment leading to loss of ambulation, swallowing difficulties, respiratory muscle weakness, and eventually death from respiratory failure. These chronic neuromuscular diseases that can affect the respiratory system can range from the diseases that is affecting higher up in cerebral cortex, like cerebral degeneration, to a lower down muscle diseases like muscular dystrophies and inflammatory myopathies. It is important to recognize the rapidity of progression in management of these diseases, because in rapidly progressive disease, when respiratory physician involvement, we need to involve early in the disease and we need to follow them up frequently. These rapidly progressive neuromuscular diseases are characterized by muscle impairment, which worsens over months and resulting in death in few years, such as amyotrophic lateral sclerosis and spinal muscular atrophies. Relatively rapid progression is seen in diseases like Duchenne muscular dystrophy, resulting in muscle impairment within a few years and significantly reduced life expectancy, and death occurs within young adulthood. Other myopathies like Becker muscular dystrophy, limb-girdle muscular dystrophy, and myotonic dystrophy experience a slowly progressive reduction in muscular function with mildly reduced life expectancy. In these diseases, we can follow these patients up less frequently. So when we study about the pathogenesis of respiratory dysfunction, there are three main muscular components of the respiratory system. One is the inspiratory muscle, such as diaphragm and external intercostal muscles, which contribute most for the alveolar ventilation. And expiratory muscles carry out like internal intercostal muscles, and abdominal muscles carry out forced expiration and expulsive effects, including cough. So let me tell you about the physiology of cough as well. For the cough, we initially do a forced inspiration and take a good volume of air into the lung, and then it is followed by a forced expiration, again a closed glottis, and then after that the glottis is open and these secretions are expelled. And bulbar muscles are important in maintaining the patency of the airway, preventing of aspiration, and for the cough reflex. Due to progressive inspiratory muscle weakness and increasing elastic load induced by reduced lung and thorax compliance, they develop progressive decline in vital capacity and increased work of breathing. Rapid shallow breathing pattern associated with increased work of breathing leads to chronic microatelectasis and reduced lung and chest wall compliance. Expiratory muscle weakness with related difficulty airway secretion clearance lead to chronic respiratory insufficiency as well as potentially life-threatening problems like pneumonia. As there is a considerable reserve of ventilatory function, respiratory failure often does not manifest until the respiratory muscle strength has fallen to a level of like 25 to 30% of the normal. Hyperventilation often first apparent at night during the sleep, particularly in REM sleep, and this is thought to occur due to decreased respiratory drive, excess loading of the diaphragm during sleep atonia, and instability of upper airway due to bulbar weakness that occurs in REM sleep. These changes may lead to sustained oxygen desaturation and hypercapnia. So, as I have mentioned to you before, the initial part of the disease, there will be normal daytime partial phases of oxygen and carbon dioxide, and with progression of the respiratory muscle weakness, nocturnal hyperventilation in the REM sleep is the first to manifest. Then, with further progression, nocturnal hyperventilation will be there even in non-REM sleep, and ultimately progressing to chronic daytime ventilatory failure with further reduction in vital capacity. So this is a diagrammatic representation of the pathogenesis of respiratory dysfunction, where because of the inspiratory muscle weakness leads to ventilatory dysfunction, and inspiratory muscle also contribute to the cough reflex, as I have mentioned before, and this expiratory muscle weakness again causing cough dysfunction, and bulbar muscles also cause upper air dysfunction that will make the patient prone for the aspiration and can result in pneumonia. These are some common symptoms of respiratory failure. The patient can have exertional dyspnea or dyspnea at rest once the disease progresses to later stages, but this exertional dyspnea may not be very apparent because of the poor mobility of these patients with neuromuscular diseases. And these patients may have increased generalized reactions, and they may have symptoms of nocturnal hyperventilation and hypercapnia like fatigue, sleepiness, nightmares, and early morning headache. And these patients also may be having features of bulbar dysfunction like dysphagia and dyspnea. And these are some important signs of respiratory failure. Single breath count is a very important bedside test which we can use frequently to detect respiratory dysfunction. And we have to observe the patient for rapid shallow breathing, axillary muscles of respiration, and paradoxical abdominal movements, and orthopnea that will be apparent in diaphragmatic paralysis. And we'll also have to examine for weakness of trapezius and neck muscles, and staccato speech, weak cough, and cough after swallowing. All this gives an idea about the bulbar function, and they may also have tachycardia. This is how you evaluate a patient with a neuromuscular disorder. First, you have to take a history where you ask about the sleep-related symptoms, and then about the symptoms related to hypercapnia, and then about the bulbar symptoms. After taking an appropriate history, we'll have to proceed with the examination, as I've told you before. You have to do the single breath count and to examine for respiratory muscle weakness. And we also have to examine for the cough reflex and the bulbar functions as well. So depending on these suggestive history and examination, we have to move on to respiratory investigations. When we move on to laboratory investigations, spirometry is a very important test to detect respiratory dysfunction in neuromuscular disease and to monitor the progression of respiratory dysfunction. There, what we would expect is a restrictive ventilative effect characterized by reduced forced vital capacity and reduced total lung capacity, the normal or low functional residual capacity, and increased residual volume. And we need to be cautious about leaks in these patients because of the bulbar weakness, and they may not be able to hold the mouthpiece tight because of the bulbar muscle dysfunction. This can give rise to erratic measurements of these lung volumes. Vital capacity measurement should be done in both sitting and decubitus position. And there's a decline of more than 25% in the decubitus position. It indicates a significant diaphragmatic weakness and probable possibility of having nocturnal hypoxia. If a post-vital capacity value of less than 55% of the theoretical value predicts the possibility of hypercapnia. These patients, we may have to do ABG to see whether there's any abnormalities. So the deterioration is considered to be severe when post-vital capacity is less than 30 milliliters per kilogram, and we can monitor the progression by using sequential post-vital capacity measurements. This maximal muscle pressures are another important investigation from which we can take individual assessment of the inspiratory muscle strength and expiratory muscle strength. Maximal inspiratory pressure represents the global inspiratory muscle strength, and maximum expiratory pressure represents global expiratory muscle strength. Maximum inspiratory pressure of less than 30% of the theoretical value is associated with significant deterioration in blood gas values. Stiff nasal inspiratory force test is another additional measurement for inspiratory muscle strength, and it is useful in the patient with facial weakness and dental malocclusion, where there are leaks in the, they can have leaks in the spirometry measurements because they can't hold the mouthpiece tight, and it is measured by plugging the device into one nostril, and then while the other is occluded, and then the patient is asked to sniff. And about 10 measurements are taken, and the sniff nasal inspiratory pressure of more than 70 excluding significant respiratory muscle weakness. The cough expiratory flow is another important measure which is used using from which we can get an idea about the expiratory muscles and the cough reflex. It is measured using a peak flow meter or a pneumatograph after a vigorous cough effort. And in adults, if the value is greater than 350 liters per minute, it is normal. and the values less than 270 liters per minute indicate impairment of cough reflex and deterioration in the ability to severe circulations. And imaging also important in assessment of this respiratory dysfunction. In chest X-ray, we can appreciate elevated hemidiaphragm in the unilateral paralysis, but in the neuromuscular disease, it is of limited value. Ultrasonography is a very non-invasive and very informative investigation from which we can get an idea about the diaphragmatic muscle strength and the diaphragmatic movements. In ultrasonography, diaphragmatic thickness is proportionate to the diaphragmatic strength, and movements also assessed. In diaphragmatic paralysis, if the diaphragmatic thickness is diaphragmatic thickness is less than 2 millimeters, and there's no does not increase in inspiration. As you can see in this diagram, in a normal person, we would see the diaphragmatic movements, and we would see there's a flat line in the patient with the diaphragmatic paralysis. And sleep use studies are also important in investigating these patients, because these symptoms, first symptoms to manifest is during sleep, during REM sleep. These neuromuscular disease patients can have different respiratory conditions depending on the predominant muscle group that is affected. If inspiratory muscles are affected, hyperventilation with hypoxia and hypocapnia can be there. When the upper airway muscles are affected, obstructive apneas and hypopneas are seen. We need to have a low threshold for overnight oximetry in these patients with severe restrictive impairments, that is the patients who are having postal vital capacity of less than 50, and with the patients with symptoms and signs of hypercapnia. If oxygen saturation is less than 90%, more than 30% of sleep duration, it is considered as nocturnal hyperventilation. This oximetry study should always be completed with a polysomnography, which will help differentiate between central and obstructive sleep apnea. In a obstructive sleep apnea, we'll see the cessation of airflow with preserved respiratory effort, and in the central one, we would see impairment of both the respiratory flow and the respiratory effort. Arterial blood gases are also important in assessing for the respiratory dysfunction. There would see a hypoxia with a hypocapnia in the initial stages due to carbon dioxide washout, and in the later stages, the patient will be having hypoxia with hypocapnia in type 2 respiratory failure. We may also be able to appreciate bicarbonate retention and hypochloremia. Swallowing assessment also important in assessing this patient, because the swallowing impaired can lead to aspiration and life-threatening problems such as pneumonia. So simple swallowing assessment is usually done by a speech or language therapist using food particles of different consistencies, and video fluoroscopy is considered the gold standard in swallowing assessment because it provides direct information about the different phases of swallowing and about the safety of the oral route. This is a summary of the laboratory data that is suggestive of respiratory failure. We can guide these values to decide on the need of NIV and further management. Vital capacity of less than 15 milliliters per kilogram, or vital capacity of less than 1 liter, or a 50% drop from the stable value, or if there's a 20% drop from sitting to supine, and the maximum inspiratory pressure values of less than 30, maximum expiratory pressure values of less than 40, and the presence of desaturation and presence of arterial partial pressure of carbon dioxide of more than 40. Those values are indicative of respiratory dysfunction. So first, we have to do the clinical assessment with the symptoms and signs. Then, if those things are present, we have to go for investigation to do the objective assessment with the spirometry, the puff flow and the muscle pressures, and then we'll also have to study about the presence of dysphagia, and it's important to assess about the cardiovascular complications as well, because these cardiac dysrhythmias are also common in these neuromuscular disease patients. And we'll have to evaluate these patients depending on their rapidity of progression. We need to follow follow up these rapidly progressive neuromuscular diseases every 2 to 4 months, and we can follow up slowly progressive neuromuscular disease patients every 6 to 12 months. And in the follow-up, we are assessing the symptoms and signs of the respiratory failure, and then the respiratory investigations as well. So when we are discussing about the management of respiration complications, there are several important things to consider when managing these patients. As these are relentlessly progressive diseases with limited therapeutic options, we need to set goals of care after discussing with the patient and the caregivers. And we also always can revisit these decisions at any point of time, and it is important to plan end-of-life care early as well, while the patient has the capacity to and ability to express his or her views. And these patients are managed in multidisciplinary approach with the presence of the respiratory physician, neurologist, rehabilitation physician, and occupation and physiotherapy, occupational therapist, and physiotherapist. So this when we go to the management of respiratory complication, once after coming into consensus with the patient and the caregivers, these management strategies can be divided into 2 arms. One is a non-invasive arm, where we would start to manage the patient in the non-invasive arm, and once these measures fails, then we are going for the invasive management. Even the patient has given his consent to go ahead with the invasive management. So non-invasive ventilation is very important in managing these patients. When the patients coming with symptoms of nocturnal hyperventilation or diurnal hyperventilation, or with the features of hypercapnia, we'll have to go ahead with the pulmonary function test. If these tests are abnormal, and we'll have to offer them non-invasive ventilation. So the respiratory failure is the most common cause of premature death in the patients with these neuromuscular diseases. And in these patients, treatment with ventilator support has considerably increased survival and improved the quality of their life. And in patients with slowly progressive disease, non-invasive ventilation stabilizes the vital capacity, increase the partial pressure of oxygen, decrease the partial pressure of carbon dioxide, and improve the quality of sleep. These benefits are significantly observed in patients who use non-invasive ventilation for more than 4 hours. This non-invasive ventilation should be indicated in all neuromuscular patients with symptoms of respiratory fatigue associated with functional respiratory dysfunction, that is measured by using the respiratory function test, and patients with symptoms of nocturnal ventilation in the presence of hypercapnia and nocturnal desaturation. And patients with who are unable to clear respiratory secretions and patients with reduced conscious level are not good candidates for non-invasive ventilation because of the aspiration. These are the laboratory values that guides us to the provision of NIV, reduction in the vital capacity, nocturnal desaturation, overnight oximetry, and arterial partial pressure of carbon dioxide at 45, and presence of nocturnal desaturation and reduced muscle pressures, stiffness, and respiratory pressures. Respiratory physiotherapy also plays an important role in managing these patients. It can be divided into preventive respiratory physiotherapy and active respiratory physiotherapy. This preventive respiratory physiotherapy is intended to maintain thoracic and lung compliance and to prevent the appearance of microathletics. Here, the chest expansion or hyperinflation techniques should be applied and can be done manual or a mechanical method. These techniques are initiated when the patient's vital capacity falls below 1.5 liters to 70% of the theoretical level. How we do this is by manual hyperinflation of using a bamboo resuscitation and ask the patient to retain air by keeping the glottis closed. And this can also be performed using mechanically using intermittent positive pressure breathing through a mouthpiece or a facial mask. Active respiratory physiotherapy is aimed at maintaining adequate drainage of the respiratory secretions, and this is initiated when the patient's cough is ineffective, that is observed through clinical symptoms or functional examination, that is by peak cough flow, the peak cough flow less than 270, we have to initiate active respiratory physiotherapy. It is again can be manual or mechanical, and it is generally performed at home. This manual assisted coughing begins with a manual maximal inhalation that is followed by retention of air by closing the glottis, and then the end of expiration give a in the positive interthoracic pressure is assisted by hand compression on the chest abdomen. And it is essential that the patient retains normal bulbar function so that allows the closure of glottis at the end of insufflation. And this insufflation in the patients who are having significant respiratory muscle weakness may need insufflation, as I mentioned in the previous slide, before the active respiratory facility. Mechanically assisted cough is indicated when effective cough is not achieved with the manual techniques, and it is performed using a mechanical insufflator exsufflator device, and this device generates positive pressure insufflation followed by a negative pressure, resulting flow of air that removes the secretions. And it can be applied via a nasobuccal mask or a tracheal tube. And prevention of aspiration is another important aspect of managing these patients. And the patient can take their diet from the enteral route as long as the patient can maintain the nutritional status with that, and there's no evidence of aspiration in the swallowing techniques. And in these patients with neurogenic dysphagia, reducing the bolus volume and increasing the viscosity of the food can increase the efficacy and safety of swallowing. And there are swallowing techniques which also can be used with modification of texture and volume, as I have mentioned before, and this can increase the efficacy of and safety of swallowing. And in patients whom dysphagia does not permit these manuals, we'll have to go for an endoscopic radiological placement of gastrostomy tube to prevent aspiration. But even though with these we can't prevent aspiration totally, because even these respiratory secretions can even be aspirated. So we'll move on to the invasive treatment strategies. These strategies are activated only when there's poor response to non-invasive strategies. And this invasive ventilation may be used in neuromuscular diseases that present with progressive weakness of the respiratory muscles, when bulbar involvement reaches a critical point where non-invasive aids to the respiratory muscles fail. And
Dr. Kamrat, sorry to disturb you. We have only about 2 minutes left. Okay.
Sure. And it may prolong survival in these neuromuscular disease patients, and it is a procedure of choice in the patients who wish to continue living when non-invasive aids are inadequate. And tracheostomy may be necessary due to both failure of NIV and ineffectiveness of coughing aids, and it is either due to lung injury or as a result of severe progressive weakness of the patient's respiratory muscles. And it is important to avoid rush decision making. For that, the patient's informed desired and with respect to tracheostomy should be obtained before the valvular involvement becomes severe. So in summary, we have to first assess the patients with the symptoms and signs. If the symptoms and signs suggestive of respiratory dysfunction, we'll have to proceed with the objective investigation, respiratory investigations like spirometry, peak cough flow, and sleep studies to assess the presence of respiratory dysfunctions. And then after that, after the agreement with the patient, definitely we have to move on to the non-invasive and invasive management. And these patients are followed up at multidisciplinary clinics, as I mentioned to you before. And thank you very much for your patience listening.
Right. Thank you very much. I just wanted to have a little time for any questions to come your way. Now, there are no questions in the Q&A box as yet. May I invite any questions from the audience, please? Anybody from the audience who is able to, some other people may have their mics on, they will be able to ask questions, the judges, etc. And then, of course, anybody other people can put it to the Q&A box. Any questions, please? We have time for maybe one question.
Dr. Gamrat, thank you very much for the very explanatory lecture. What is your experience in Sri Lanka about these neuromuscular disorders and the respiratory rehabilitation?
Currently, we are still in the preliminary phases of this respiratory rehabilitation. We have started the clinic for the neuromuscular palliation, and we are recruiting patients for that. And we are doing these lung function studies and these muscle pressures at the moment at the central chest clinic. And we have got down this insufflator exsufflator device, and we have started providing care for these patients, and still in the initial stages.
Thank you.
Maybe one more question if there is. Right. In the absence of any further questions, may I thank Dr. Gamrat on behalf of the Ceylon College of Physicians. We will be sending you the certificate. We may be able to show you on screen the certificate. Is that possible, Ms. Nalina? So this is the certificate of appreciation from the Ceylon College of Physicians to Dr. Gamrat for his excellent presentations at the Young Physicians Forum. So good luck in all your future endeavors.